All right, today we're putting on our detective hats. We're going to crack the case of what our lungs are really trying to tell us. And our main set of clues, they're called pulmonary function tests. So let's dive right in. You know that feeling, right? You're just walking up a flight of stairs and suddenly you feel way more winded than you think you should. Or maybe you've got that nagging cough that just won't quit. Well, those aren't just little annoyances. They're actually the very first clues in a medical mystery. So when you bring these clues to your doctor, they don't pull out a magnifying glass. Instead, their first move is usually to suggest a set of tests. And yep, you guessed it, those are the pulmonary function tests, or PFTs for short. They're designed to take those kind of vague feelings and turn them into cold, hard data. So what exactly is in this lung detective's toolkit? Well, PFTs aren't just a single test. Think of it more like a whole collection of tools. Each one is designed to look at a very specific piece of the puzzle so we can build a really complete picture of what's going on with your lung health. At the end of the day, all these tests are really doing is measuring how well your lungs are working. Simple as that. And maybe the best part? They're non-invasive. We're not talking about needles or anything scary here. It's literally all about analyzing the way you breathe. Okay, so our investigation really boils down to three key questions. First up, ventilation. How well are you actually moving air in and out? You can think of this like checking the pipes. Second, gas exchange. Okay, the air is in, but is the oxygen efficiently getting into your blood where it needs to go? And last but not least, lung size. Just how much air can your lungs hold? Are we working with a full capacity system here? You know, in every good detective story, there's always that one piece of evidence, right? The clue that just breaks the case wide open? Well, in the world of PFTs, that clue is a test called spirometry. It's pretty much always the starting point, and honestly, it gives us the most critical information right off the bat. So what is spirometry? The concept is actually super simple. You just take the deepest, biggest breath you possibly can, and then you blow it all out, as hard and as fast as you can, into a little machine. That's it. But don't let that simplicity fool you. The data that little machine captures is incredibly revealing. Okay, so that machine is watching two really important things. First, there's your forced vital capacity, or FVC. That's just the total amount of air you can blow out after that huge breath. Think of it like the total size of your gas tank. But just as important is the FEV1, the forced expiratory volume in 1 second. This one measures how much of that air you can blast out in the very first second. It's all about speed and power. And this is where it gets really clever. It's not just about the total volume, and it's not just about the speed. The real magic, the big clue, happens when we look at the relationship between those two numbers. That ratio, that's the fingerprint that's going to help us identify our culprit. And what's the magic number? It's 70%. See, with healthy lungs, you should be able to blast out over 70% of all that air in just the first second. So that number, 70%, becomes our critical dividing line. Are you above it or are you below it? Because the answer to that one question is going to point us in one of two very, very different directions. Okay, so once we know if you're above or below that 70% mark, we can start to zero in on the two main types of lung problems. These are our two main suspects, if you will, obstructive disease and restrictive disease. Now, they might sound kind of similar, but trust me, they are fundamentally different problems. All right, let's break down our suspects. With obstructive disease, the big problem is getting air out. The best way to picture this is trying to breathe out really hard through one of those skinny coffee straws. See how the air gets stuck? It's trapped. Now, with restrictive disease, the problem is getting air in. The lungs themselves just can't expand properly. They might be stiff or smaller. It's like trying to inflate a really small, tough balloon. It just doesn't want to stretch. This is where the evidence really starts to make sense. Let's look at how the numbers point to the culprit. See that obstructive column? The dead giveaway is that FEV1/FVC ratio. It's low, less than 70%, because you just can't get the air out fast enough. But now, check out the restrictive column. Here, the ratio is actually normal or even high. The big clue for this one is the FVC and TLC, the total lung volumes. They're low. The tank itself is just smaller. Okay, so spirometry points us in the right direction. We know if we're dealing with an obstructive or a restrictive pattern. But the investigation isn't over yet. That's just the first step. Now we need to gather some more clues to figure out the specific cause.
And this is where another test called the DLCO comes into play. What this one does is look at gas exchange. Basically, it answers the question, are your lungs just holding on to air, or are they actually doing their job of passing oxygen into your blood? A low score on this test, for example, can help a doctor tell the difference between something like asthma, where gas exchange is usually fine, and emphysema, where that exchange process is actually damaged.
All right, we've gathered all our evidence. We have the spirometry ratio, we have the lung volumes, and now we know how efficient the gas exchange is. It's finally time to put all these clues together and crack this case. This is basically the exact diagnostic path a doctor follows. It's a really logical process. Step 1, always, is to check that ratio, the FEV1 over FVC. Is it low? If yes, boom, we head down the obstructive path. If it's normal, we move to step 2. Check the lung size, the FVC. Is that low? Well, that points us toward a restrictive issue. And from there, step 3 is using that DLCO test to really nail down the specific disease. And this systematic approach is how they get to a final verdict. So, for example, if you have an obstructive pattern, but it's reversible with medication, that's the classic fingerprint for asthma. An obstructive pattern with that poor gas exchange we talked about, that's pointing towards COPD or emphysema. And a restrictive pattern with a really low DLCO, that often reveals a condition like interstitial lung disease. So what's the big takeaway here? It's that pulmonary function tests are the key that unlocks the whole mystery. They take something subjective like, I feel short of breath, and they turn it into objective, concrete data. And it's that data that leads to a clear diagnosis. And having a clear diagnosis is absolutely the most important first step to getting the right treatment. Look, your lungs are telling a story with every single breath you take. What PFTs do is give us the language to finally understand that story. They give both you and your doctor the power to finally listen to what your lungs have been trying to tell you all along.